Hey guys, you're watching the Best Practice Show. We take a look at the best business practices from the best dental practices all across the country. And today we are going to examine one of the most controversial topics in all of great restorative dentistry. Should GPs place implants? With the guy who explains this better than anybody, my good friend, Dr. John Cranham. Don't miss this. Grab a pen and hit the share button. We'll see you in a second. Hey guys, thanks for watching the Best Practice Show. Welcome back. We are having so much fun, and the viewers, and I'm thanking all of you for all the shares. This is crazy how much fun we're having. So, and getting a lot of great feedback about stuff you want to see. And today is no exception. So we're going to fly right into the eye of the storm. You don't want to miss this conversation. But a couple show notes. Here's what I'm going to say. We are shooting this episode live on Facebook. So if you're watching this live, do me a favor, ask a question right in the feed, and I'll ask John directly, and we'll get the answers straight from the top on this, because I know you're going to want to ask questions on this one. And then also, we just love the questions so much. Every week we give away a free Apple iWatch and 2 tickets to our Practice Growth Seminar called Activate, just because I love the questions, and the questions get better and better every single week. So please keep asking them. Now, on this particular episode, I'm going to just say this. I am a huge fan of high-quality restorative interdisciplinary dentistry. If you watch the show, you already know that. I just love when people do amazing stuff together. And the question I get this question, I'm not kidding, several times a week. Should GPs place implants? Should they not? I have so many of my dear friends that are Seattle Study Club directors and, periodontists, oral surgeons. They place and they just do incredible stuff. And so they're seeing this trend. We're seeing this trend. Let's talk about the trend. And I've got my good buddy, Dr. John Cranham from the DOS Academy. Now, I'm going to introduce him myself, and then I'm going to have him share his story. In 2005, as my Pete Dawson was always an incredible mentor of mine. And then in 2005, I flew up to Traverse City, Michigan, and I just made a decision that I was going to have a good friend who would mentor me. And, hopefully it worked out for me. I told you were going to mentor me, and you were like, I'll decide that. And so you've been a great clinical friend and mentor, and just I've learned so much. And the thing, I'm going to say this about you, the thing I love about you is you do love to walk that line. And it's not because for any other reason. It's happening all the time. You see every industry, especially this industry that we care about so much, it's changing. It changes all the time. And so I want to talk about that. But before we do, just tell us your story. For if anyone doesn't know who Dr. John Cranham is, who is Dr. Cranham?
Oh, yes. So I guess I'm a dentist that's almost 30 years in now. Heard Pete Dawson 6 months out of dental school and was blessed enough to get my tuition paid by a local lab guy to send me down there. Heard him, went through his courses twice in 2 years, and then started chasing around some of the cosmetic guys back there in the early 90s. And what happened to me was about 95, 96, it occurred to me that integrating some of the traditional approaches to occlusion with the emerging cosmetic dentistry, the things that were happening in cosmetics dentistry make sense. And for those that are new, don't it's hard to imagine, but they were sort of diametrically opposed at that time. And I created a lecture called The Cosmetic Occlusal Connection, which got me going around the country. That was, again, controversial at the time, walking the line, as you say. But then in 2003, got scouted by Dr. Dawson, and he invited me to come in and became the clinical director and one of the owners in 2007, and I'm still one of the leaders and involved with a lot of the lectures and hands-on and going all over lecturing, but still in my practice 3 days a week doing the best dentistry I know how to do. So it's been an amazing journey for sure.
Yeah, and if you haven't heard of the Dawson Academy, you got to go. I was just down there with you guys at the alumni event, which was just an incredible weekend. And you're not just in Florida anymore. I mean, you guys are all over the world.
Yeah.
Japan, India,
China.
It's crazy.
Yeah,
so
it's great.
Check it out. So let's talk about this. Let's go right there. Why is this such a hot topic? Why?
Well, I do think that everybody. I think there is a little bit of a turf war going on. But I think that one of the things that I think about that's hard to imagine, but back in the sort of late 50s and early 60s, it was kind of controversial for general dentists to do crowns. They were sort of done by prosthodontists at the time, and dentists were there to fill teeth and clean teeth and do the nuts and bolts. And I do think as things have evolved, the training that general dentists are exposed to have expanded. Right. Having said that, though, I do think that when we look at the whole spectrum of implantology and doing implant surgery, with the technology we have today, there are certain surgeries that are very, very simple, and there are certain surgeries that are extremely complex. And so, like anything, a little bit later we'll talk about this concept of the green, yellow, red, which I think every dentist should be thinking about with any procedure they do, whether they're taking a tooth out or doing a crown or a root canal. I mean, we face it all the time. We need to know what our sweet spot is in our practice, where we're capable of, because the minute we delve into something like an extraction or a root canal or placing an implant, we have to remember we are held to the standard of the specialist. And so if we're going to go down this road, we can do it. For me, my training, I had training early in the 90s by Dr. Mish, and I went and did some of that training, and there was a guy in the Orlando area named Tom Ford who spoke with Picos, Mike Picos at the time, and I went down there and took their classes. Tom was interesting because he went to the same high school I did in Grand Rapids, Michigan. His uncle was Jerry Ford, who was the president, and so our families knew each other, and so I was intrigued by, first, certainly the prosthetic aspects of it, and then I got intrigued by the surgical part of it. In the early 90s, though, there was no cone beam, so it was very unpredictable in terms of you didn't know what the bone was going to be until you got in there. And I'll talk a little bit later. For me, getting a cone beam in my practice, primarily for looking at joints, once I had a cone beam in and started doing some of the treatment planning aspects of it, it made me want to revisit some of the surgeries. But I get it's controversial. I also feel like for me, in the dentists that we see, particularly the young dentists that we see, there are so many young dentists that are drawn to it. And my greatest concern is dentists learning to place implants before they really know where the tooth is going to go. Right. And so to me, implant surgery is such a prosthodontically driven thing that that there's just a lot to it beyond just the surgical technique. It has to be done in a way that we three-dimensionally visualize where things are. So that's it. I do think that if we think about why implant surgery is something that, why would we implement something like implant surgery, which if we go to slide 1, we can take a look at that. There's sort of 5 things that I think about that sort of drew me to it. And the first thing is that, I have a remarkable interdisciplinary team that I work with, orthodontists, a couple of orthodontists, a surgeon, as well as a periodontist, which I'll talk about later, which I probably learned more about implants from him than anybody, but some of the basic surgeries that we're capable of doing has actually made me a much more valuable member of the interdisciplinary team, because I understand sort of limitations sometimes. I'm recognizing the areas that are more simple and the areas pre-clinically that are going to be more difficult to manage. I do think when we're developing a practice and doing procedures, there isn't any questions that people like to have their services done in one place if they can. I mean, they have their relationships primarily with us, and people are busier. So the fact that they can have their diagnostics and their plan and the treatment done in one place is attractive if the care is going to be as good, and that's the key. It sometimes can give the restorative dentist greater control in terms of if you're removing a tooth, or if it's an immediate placement and you're making a custom impression coping and really trying to control the tissues, that can sometimes occur. It's certainly going to add a revenue stream to the practice that maybe not there, which I think drives a lot of it. But I tell you, for me, the biggest thing that drew me to it is, and I think you chuckled about this when I presented this at the alumni meeting, but we talked about as dentists, we go through these levels of implementing new things, and we start at sort of the level of being unconsciously incompetent when we're bad and we don't even know we're bad, and then we become consciously incompetent, and then we get consciously competent. If we keep going, we become unconsciously competent. That means we're good at it and we don't even have to think about it. And one of the things, at least in my personality type, if everything that I do is at the level of unconsciously competent level, it sounds like it would be great, but it can start to become boring. And I freaking love to be at that level where I'm good at something, but I really have to think about it. Implant surgery gets my heart rate up, and it gets me excited, and it stretches me. And so, it allows me to plan. So even if I'm not going to put the implant in, I'm still the one three-dimensionally visualizing where it go and making the guide. But I love how it stretches us, and the simpler ones, maybe a couple a month, 5 to 6, 7 a month, we'll put in. The rest we go out. So that's sort of why.
Yeah, and can you talk about this trend too? Because I've seen this for years, and this isn't just about how good you get. You've told me this over and over again. Your vision at the Dawson Academy is make sure you guys are in the front end of what thinking is going on in dentistry. So you guys have seen this for years. This is not new. I saw it back way before 2010. A lot of the specialists I was working with and still work with today, they're like, oh, me and my GPs are starting to place implants. Now, you can go one of two ways. You can go off the deep end and get angry, or you can say, hey, look, it's a trend, and embracing the actual trend. And you guys saw this at the Dawson Academy, correct?
Yeah, and it's the same with ortho. It's the same with, I remember that 10 years ago, everybody thought that chairside CAD cam, if you were milling chairside, that all that dentistry was terrible. It didn't actually go to a lab. People are shocked that we mill some crowns on our office. So I'm a big believer in embracing technology if it's going to add some sort of increased predictability, increased efficiency, and increased profitability to the bottom line. That's that PEP thing we talked about last time.
Right.
And I certainly think there's some technologies that when we start looking at that don't really help that. But the question is, as this sort of this concept of the super generalist, and that's really what we're talking about, this concept of a general dentist who keeps up 100% of everything in-house. That's not what we're talking about here at all. What we're talking about is a general dentist who becomes extremely knowledgeable and expands and grows and develops great clinical techniques and develops a way to know where certain things should happen. And part of that responsibility is certainly to develop the relationships with the team, understand when absolutely a team is going to be needed. But I've found with my specialist, I don't see them incredibly intimidated by my implant surgical skill, because they know that I'm going to pick the ones that have great bone and great attached tissue and are going to be fairly easy for me to do, mostly guided, a lot of times flapless. We'll talk about that a little bit more. But I think that the concern is, and the concern is legitimate. And your point, I think you're alluding it to, is like anything. It's the same thing as for the person who buys the CEREC, and now every time they do a CEREC, 100% of their crowns are being made by the CEREC. Well, a CEREC is not a 100% thing. It's a sometimes thing. And
Right.
I've made some incredibly beautiful crowns with my CEREC machine on good stable occlusions and good preparation design and scanning. And I certainly think along with orthodontics, Invisalign by a GP can be very, very successful in the right cases. The key is to know when it's appropriate and when it's not.
Yeah. So let's examine that question, because that was my next question. When and when to not? Let's say let's speak to the young practitioner might be watching this, who's maybe 32 getting started. How would you answer that question?
Well, let's talk about what I want to do is maybe take you on a little journey here.
Okay.
And I think maybe the way to think about it is, how the heck did I get to this point where it's probably been about 6 years. So at about 48 years old, all of a sudden I thought, I'm going to start placing implants. That was sort of a wild thing, because in my practice, I had become so interdisciplinary driven. I wasn't even taking out a lot of teeth. I mean, I did some aesthetic crown lengthening and was comfortable laying flaps to raise the tissue levels on the simpler ones, but a lot of them went out to the periodontist. And so let's look at sort of the steps that we went through, and then maybe you can kick around questions back and forth off of that, and we can kind of go through some slides here.
Love it.
And use the slide technique that you're excited about. So.
We haven't done this before.
Yeah. So if we go to slide 2, let's look at steps to implementing implant surgery as a GP. And the first thing that we talk about is that to master the treatment planning and restorative protocols for implant services. So what we mean by that is that and again, it sounds like, master, it sounds like an easy thing, but the one thing for me that I look at it is I spent literally the first 20 years of my life as a dentist really understanding where teeth go from an aesthetic and functional perspective. So, designing cases that were going to be beautiful, but also stable occlusally. And so that means learning how to evaluate photographs and mounted models and centric relation. And so I felt like, as I started to study more about implants, that a lot of that training really helped me, because the first step in figuring out where an implant's going to go and whether you should do it is to first figure out where the tooth should be, and then have a way to figure out where the implant should be. And then the third thing is to understand some of the biologic differences between implants and teeth, because it absolutely affects our outcome. So if we can go to slide 3 for a second, one of the real simpler things to understand is that if we look at the soft tissues of teeth, and these happen to be veneers that I place, so it's all natural teeth, but I'm sort of simulating the difference between implants and teeth. That when we have all teeth present, the scallop of the underlying bone is going to be flatter than the scallop of the overlying tissue. So interproximally, if you have a papilla that touches the contact point, there's essentially a 5 millimeter space from the contact point to the interproximal bone. And then straight facially, it's going to be about 3 millimeters on average. When you start putting an implant in, we need to have the head of that implant about 3 to 4 millimeters from the free gingival margin, but the scallop of the bone is going to be less. So from our contact point to the interproximal bone, you're only going to have a dimension of about 4 millimeters. And then we have 2 implants next to each other, that scallop decreases even more. So the papilla is going to be less pointy, and it's going to be about 3 millimeters from the bone. So one of the things that's important about a lot of this research is the understanding that we think a lot about the buccal lingual position of where the implant should be, so it's in bone, but what we forget a lot about is how deep the implant needs to be. And so we can only plan how deep the implant needs to be if we first figure out where we want our incisal edge, where we want our gum tissue, and then from there, how deep the implant needs to go. And I don't know any other way to treatment plan this other than to carefully look at it on my mounted models and on my photographs, and then relate that information to the cone beam. And so this really sets us up well. So if we go to slide number 4 there, what we're talking about then is that we need to first sort of visualize where our cuss tip or incisal edge is going to be. Then we need to visualize where the free gingival margin is going to be. And then we can figure out how deep we need the implant. And this basic little parameter here is what was taught to me over and over again by working with my periodontist. And so with that, I think that it's important for us to recognize that specialists, the better specialists, really get this. Al Konikoff is the periodontist I've used for years. We did a lot of cases, crown lengthening cases and grafting cases. And quite frankly, when we started doing implants together, a lot of this content was in his head. And what he did for a lot of us as GPs is we would send him the implant. He would figure all this out, put the implant in, put in a custom healing abutment, mature the tissues, and then tell us it was ready for an impression. And we didn't really realize how spoiled we are. So right. As time went on and we started to meet, we used to have those little interdisciplinary meetings every month, and I started to watch what he was doing. That's where a lot of this learning came for me, was doing cases with him and really getting clear on that. So let me look at slide 5 there for a second and show you a really early case that we did. This goes all the way back to 97.
Okay.
Tooth number 9 is extracted here, thick periotype, patient lost 9, had a bad post in it. We were going to do veneers all the way across before we recognized that the tooth was a failure, was going to fail restoratively. And so I sent her over to Albert. And what Albert did in this case was essentially put in the implant, put in a cover screw, and then used a flipper and contoured the bottom of the flipper to shape the tissue. Now, I didn't know what he was doing, but what he was doing was he was creating a vehicle to protect those papillae from collapsing. And again, we did have the thicker periotype to help us, but you can see that the tissues look pretty good. We go to slide 6. This is the 14-day post-op after me putting my veneers in and my crown. And what you'll notice here is just a teeny tiny black triangle between 8 and 9. Now, what we didn't know at this time was that implants are different than teeth. I put my contact point exactly 5 millimeters from bone, and it should have grown in if those were 2 teeth. And so it was shortly after this that some of Tarnow's work came out that showed us the differences between implants and teeth. Today, we would make that contact point up a little higher. Albert did everything right. I maybe was a little slow restoratively here. But look what happens at 6 months. At 6 months, we go to the next slide, slide 7. It completely fills in. And the only thing that I can tell you is it wasn't because we added porcelain, we just got lucky. This is a patient that had a thicker than normal periotype. But it was this case that while we were doing it, that he was reading some of the perio literature and we started changing some of the dimensions. And I started really understanding that when we take teeth out, we have to support those papilla. We have to do whatever we're going to need to do, whether it's with a provisional or a custom healing abutment or something, to support those papilla. Albert taught me that preserving dental aesthetics is much more predictable than recreating dental aesthetics. So if those papilla are beautiful, let's preserve them at all costs. The other thing we learned is from him along the way, if we go to slide 8, is that when we place these implants in, to not obliterate the socket. Way back, and I can't remember the date, but Albert and I published an article in the 90s, and it was on immediate load implants, which was thought of as a wild concept then. And so we were using a Freelite implant. We took the implant out, took the tooth out, put the implant in, and obliterated the socket. And then he went through all his gymnastics. And at the end, we have this really beautiful crown in place. But when you look closely at the pictures, you see just a teeny bit of blue through the tissues. And what I learned from writing that article is that when you write things, you preserve your ignorance for your prosperity. Because, of course, what we know now is you don't obliterate the socket. And so we started putting in narrower implants, more to the palatal, and actually leaving a gap like we're showing here to allow that bone to fill in. And, but watching him make provisionals, and this is a great case because this is a case where he literally puts on an abutment on the crown. And if you go to the next slide, basically uses the patient's tooth, reams out the inside of the tooth and picks up the abutment right on the implant. Okay. That makes sense.
Absolutely. Absolutely. So, and then as you look further down, like you're a big protocol guy. I want to get into how you think in this whole process now, as you've taken all this learning, you put this all together. Tell us about that, the steps and the protocol, and just how you think about this now.
So, and again, I the way I look at it, the reason I think that our students, the people that go through Dawson, are so ready to do implants is I feel like we teach them to do the hardest part, which is to go through all the normal dental examination stuff that they've trained to do to dental school, but then also add layers to it of taking a series of photographs, being able to put it into our Dawson Diagnostic Wizard to first visualize aesthetically where the teeth and the tissues should be, take that data, and then to be able to put it on mounted casts so that we can develop a good occlusal design. And if we do those two things, the only thing that remains is then to take a cone beam. And if we can relate the tooth position to a good implant position three-dimensionally, well, now we have the protocols to do guided surgery, and that's really what I'm going to. If we go to slide 10 here, the second thing that in the steps to implementing implant surgery as a GP is to master a protocol to control implant placement. And that means designing your own surgical guides based on an optimum tooth position. So again, if we go to slide 11, this is just a nice example, very simple, simplistic example on a cone beam of what we can see. Patients missing an incisor, we can basically fabricate a tooth from our models that verifies where we would like it to be from incisal edge to free gingival margin. We can scan the patient with a radiopaque version of that tooth in place, and then we can put the implant in. Now this is, I have the Sirona product in my office, so we have the Galileos, and we have the capacity to do intraoral scans. I'll show you what that looks like in a second. But the bottom line is, however you do it, you just have to master a protocol. One of the more interesting companies right now, actually a guy that would be interesting for you to have on is Brett, who's the owner of a company called Implant Concierge, which is a pretty amazing company from the standpoint it has a way for you to send models to them or intraoral scans to them and a cone beam, and then they can do all of this stuff. They can merge the data, and then you can get online and position the tooth and position the implant, and they can make the guides for you at a very reasonable price. So it basically holds your hand through the process of figuring out all this stuff, whether it's a single tooth all the way up to more of an all-on-4, all-on-5 type situation. I don't care what method you go to. The key is first figuring out where the tooth's going to be from incisal edge to free gingival margin, and then figuring out where the implant's going to go, buccolingually and depth. And if you notice on this picture how we can clearly see where the facial margin of our restoration is going to be, that allows us then to measure from that facial margin to the bone. And that way I can determine whether we have to add bone, whether we have to take away bone, or if the bone's in a great spot, whether we can just do it guided, or we don't even have to flap it, flapless surgery, which you can do flapless surgery on a patient. I mean, honestly, the patient doesn't even know anything's been done. I mean, they don't even take a Motrin afterwards. But that's sort of the deal. I mean, if we can kind of visualize that, that's what we're talking about. And so I think that just like everything, whether we're talking about orthodontics, veneer cases, implant cases, Where I see dentists skimping
Mm-hmm.
is on the planning. They're too quick to get in there and putting the implant in or prepping the case for the veneers. There's not enough aesthetic and occlusal design up front to get crystal clear on where we're going. And with implants, I think it's even doubly important, because once that sucker's integrated, you're living with it. And we've all been practicing for long enough to know that we've had to live with a poorly placed implant, and it's hard to recover from it.
Right. Right. And sometimes, I mean, you see this too, the motivation for doing this is just wrong. It's purely financial. I mean, what you're talking about is just the learning. It's always in the best interest of the patient, and staying within your scope of what you do really well. Now, what are some of the pitfalls? Like, if I'm watching this, I think it's a great idea, but what are the things you would some warning signs that you would say on both sides, either specialist or GP?
I think I can speak better maybe from the GP, because that's what I am. But I think from the GP side, I think that the most important thing is to be conservative on when you think you should be doing it. I mean, you're going to be referring more out than you do, for sure, in the beginning. I mean, you're going to be and I always sort of think, even at my level where I've done a lot of implants, I'm still probably only doing 30 to 40%. I'm still referring much more than I'm doing. So I think that you hit the nail on the head. If we're doing anything to a patient because of the dollars that are coming from the procedure solely, then we have to rethink that.
Right.
I'm a firm believer that great dentistry dollars are going to be a byproduct of that. And so if you can look at a procedure and you can visualize it and you feel like you can do it as good as your specialist, then have at it. And then I think from a specialist perspective, I think the specialists that are a little bit more open to some of the trends that are happening and actually can be a help to a general practitioner. What I find is that orthodontists that help GPs do some of their own tooth movement, whether it's with an Essex aligner or with its Invisalign, dentists who get focused on moving teeth refer more ortho. They start doing more ortho. It becomes part of what they see day in and day out. And if you can help them see the time that they can do it and the time that they're going to need help, I think everybody wins. And I think it's the same thing with implant surgery.
Yeah, and I think I love what you're saying. You shared with me a long time ago how your orthodontist really created a whole lot of value for you once you started going down this path. And you're like, oh my gosh, I wouldn't even try to do what you're doing. But yet having a very transparent conversation among both. And I think one of the trends, you could probably speak to this, is not having the conversation and then the relationship deteriorates. I want to say this, the reason you work with a great specialist isn't so much, it's not procedure specific, it's a trust collaborative experience that makes it all better for the patient. And one of my favorite, Gene Ranieri, who's a surgeon, he says this: when my GPs place implants, you know what I say? Let me help you. Let me come over. I'll do it at the end of the day. I'll watch you. I'll help you so that you don't get yourself in trouble. And inevitably, every one of them say he's the coolest guy ever, because I wouldn't attempt what he does. And I also know when I'm going to get outside of my scope and get in trouble. So it's important to have this conversation instead of not having the conversation. Would you agree?
Yeah. And again, I also think that if you're having conversations with a patient, with a specialist, we don't meet as much as we used to, but for years we met once a month for an hour and a half. My specialist, my orthodontist, surgeon, periodontist, and we really developed our protocols with working one another. The more that I learned to think like a master orthodontist or a master periodontist or a master surgeon, didn't necessarily mean that I had all the skills, but I did know how they were thinking. Right. And so my point is that you don't want to have the conversation when you're in trouble. If you're thinking about going down this road, be open with your specialist about what you're doing. And it's particularly if you're having the goal that, I want this to be a sometimes thing, not an all the time thing. But I also think that, what specialists also are looking for is a restorative dentist that has the capacity to talk to patients about getting patients to accept implants. So again, I believe that when a procedure comes into a practice, the more we're thinking about it, the more it's going to happen, whether it's in-house or outside the practice.
Right. And add some color to the whole ethical conversation, because we talked about this before, the ethics of this, because, sometimes people don't listen and they'll just react. And so I think ethically, we've got a responsibility. Number one, just do the right thing. Number two, pay attention to the trends. Can you just add some color to that?
Well, I just think ethically, there just isn't any bones about the fact that if you do a procedure on a patient, whether it's ortho, implants, taking out third molars, IV sedation, whatever it is, if you're going beyond the scope of usual and customary general dentistry, we need to know that if something goes wrong, we are going to be sitting there being judged by not general dentists, but by specialists. I mean, they will be the ones that are at the hearing and all that. So we have to be as good, or maybe not better, than the standard of care at the specialist. So everything's got to go well. That's the bottom line. So ethically, I have no problem with any dentist that's been trained to do a procedure and can do it as well as a specialist. And again, this is just throwing it out there, but this is the reality of it. I've seen a lot of implants placed by specialists that aren't great. So it's not like if just because you have a specialist degree that you're going to put 100% of the implants in perfect 100% of the time. It's the same thing with orthodontics. One of the things that's driving Invisalign is because a lot of people aren't always 100% satisfied with the occlusal result that comes from orthodontists. And that's not to say all orthodontists, but the reality is, with the technology that we have today in orthodontics, when you went to school years and years ago, a lot of the skill was in actually bending the wire. Well, pushing teeth around isn't as difficult as it used to be. The difficulty is in treatment planning. So the best orthodontists are good treatment planners and pick the right cases. Today, implant surgery, used to be that what was really difficult about implant surgery, it wasn't very predictable because we didn't have cone beam, and you had to flap and the design and all the things that would be able to graft on the fly. Well, with some of the technology we have today, there are cases that are slam dunks with guided surgery. So the trends are being driven by the fact that we do have technological advances that make some of these things easier. And so just as long as the general dentist is understanding what they're getting into and they're going to be doing it at the level of the specialist, I personally think that these type of trends, again, this might be a little controversial, but I think these type of trends only push the envelope of quality even higher.
Right.
That's what I'm hoping for. Yeah.
Right. And you're heavily involved with all the technology and the thinking process around the future. What can we expect to see in the next couple of years? I mean, everyone can only guess, but I'd love to know what you think we will see in the next 2 to 3 to 5 years.
Well, there's always the crazy outliers, but I don't think that there's any trend that more and more we're going to be going to modelless type surgery. In other words, no impressions, everything's going to be scanned, everything's going to be merged into a cone beam, and we're going to be doing more and more things completely guided. That's already happening at the highest level, but there isn't any question that seems to be the easiest way for us to relate the tooth position to the proposed implant and actually get the implant there. As I said, I've talked about it already, and I want to be clear, I'm no financial, compensation of Implant Concierge, but I'm so impressed with where that company's going because it's taking a lot of the things that we're talking about and making it so easy for either a dentist to work by themselves or for an interdisciplinary team to make a plan, get on a go-to meeting with their planner, and everybody make the decisions like that, and then have guides and custom healing abutments or provisionals all fabricated without even an impression being taken other than a digital scan. It's pretty cool. So I think that's going to be where it is. I just think that as we go down the road, more and more we're going to have to fly by the seat of our pants a whole lot less. And that's really where, if you think about great implantologists 20, 25 years ago, I mean, they were cowboys. I mean, they were doing stuff that was just, there was just wasn't near the technology, and you had to just have, you had a lot of testicular fortitude to be doing some of the things they were doing. Right. Today, I think we have a much better handle on first planning, tooth, gum position, then putting the implant in, and then making a realistic decision about what we should be doing and what we shouldn't. And the second here, we'll talk about that green, yellow, red concept, the concepts that we do and the concepts we stay away from.
Yeah. Any other considerations that you would say are pretty important before we go into the green, yellow, red?
I think it's just going to fall right into this. I mean, I think for the general practitioner, what everybody wants to know is, what are the optimum clinical conditions that I look for? Right. And if we go to slide 12, we can start talking about that. Okay. So number 3 in steps to implementing the implant surgeon as a GP, we want to look for those optimum clinical decision or conditions. And what I look for is good attached tissue and adequate bone that's in the right place. So as a GP, my comfort level, I don't like to have to take away a lot of bone or add a lot of bone. So I'm going to think from incisal edge, free gingival margin, and then allowing for that 3 to 4 millimeters of depth. And so if we look at what kind of cases that to begin with, again, the green, yellow patient, green, yellow, red, if we go to slide 13, the green patient is the one with adequate bone, adequate attached tissue, thick periotypes. Premolars are awesome. Premolars are great ones to begin with. Anterior mandible is great. And then my preference is to do open or closed guided surgery. And I'll show you what these surgical guides look like. But honestly, if we're doing guided surgery and with one of the kits, if we've done all the work in advance, what Pete said it best. He said it looks like an orangutan could have put that implant in, and it's kind of how it is. The guide's solid in there. That's if you know Pete, that's so
right.
And then the yellow patient is the maxillary anterior with optimum bone and periotype. So the maxillary anterior can be risky for sure, but again, if you think about some of the training that I had with my periodontists about really understanding papillas and holding those papillas intact, the surgery when the bone is optimum isn't that difficult up there. It's when the bone is missing or the tissue's trash that it becomes difficult. So again, optimum bone, optimum periotype. And then the red patients for me are insufficient bone, insufficient attached tissue, thin periotypes. And a thin periotype for me is if we put a probe in the sulcus and I can see the probe through the sulcus, I don't touch that one. Patients needing IV sedation, so really anxious patients, I don't mess with. And of course, these full arch implant cases, or just big implant cases where there's going to be a lot of tabling of bone or grafting, those are the type of cases that I'm working with my team on. So again, if we look at sort of the green is a no-brainer, the yellows we're looking at a little more carefully, but again, it probably accounts for about 30 to 40% of the implants that I put out. So let's look at some examples. We go to slide 14. Slide 14 is a great one. I've got the little circle there on the cusp tip of the lower premolar just to remind you to watch out for that, because that plunger cusp can mess up the occlusion. But when we look at this patient, she's got gobs of attached tissue. She's got a nice broad ridge. When we plan the case from incisal edge to free gingival margin and bone, this is a patient that I can pretty much do guided. And this was an older case where I didn't have guided surgical capabilities for that at that time, but we still had cone beam, and we could, if you go to slide 15, plan where our implant's going to go, and I could see that if I just followed the root contours or the crowns of the teeth adjacent, that I'm going to be safe. And so with that, going to slide 16, putting the implant in that position place properly, putting in our sulcus former, it's a fairly good one. We want to make sure that we're staying about 3 millimeters away from adjacent teeth. 2 millimeters away from adjacent teeth and about 3 millimeters away from another implant. That's another sort of the trend that we're looking for.
Okay.
But premolars are great. Let's look at slide 17 as another example, which is a more difficult situation where we've got a patient who's losing tooth number 8, has some bone loss. And one of the things that we've gotten pretty good at, going to slide 18, is transitioning that area to something that has bone. Now, I'm showing the implant going in, but what happened between slide 17 and 18 was we extracted the tooth and we basically used the root of the tooth. We packed the area, we cleaned it out with bone and the Dynablast material, made a membrane with gel foam, and then basically just bonded the tooth in position after cutting the root off. Waited 5 months and then came back and put the implant in. So grafting, to me, a simple socket grafting procedure, can take a red case and turn it into a yellow case. And that's sort of what we did with this case. Going to slide 19, you can see this is how we just bonded the patient's own tooth in place and kept some of the root form there to support the papilla. And then if we go to slide 20, we can see, go back to slide 19. Notice that when we take the provisional off, how you can see the implant in the base of that socket and how we've been able to manage and create that perfect sulcular epithelium. Now we can go to slide 20. And again, taking a case where you've got a lot of bone loss to that second picture where we're using the root of the tooth bonded to the adjacent teeth to hold the bone graft, to then placing the implant and shaping the tissues. So if you're a young doc and you're thinking about placing implants up and you haven't even done a lot of bridge work to change the shape of tissues and all, that's what concerns me, because 95% of it, well, maybe not 90% of it, but a lot of it is maintaining those tissues so that we can get a great result as we go through.
Yeah, absolutely. A lot to think about. Gosh, as far as, well, again, I keep going back to protocols or processes. What are some questions to consider for younger dentists watching this? Like anything else that you'd say, hey, look, this is a clear consideration you need to ask yourself as you look at the future and maybe doing some of this?
Well, I think as a young dentist, I do think that I'm a firm believer that this is going to happen. I mean, I think that as we move forward, I mentioned last time I have a daughter who actually is finishing her first year of dental school this week at University of Louisville. And as I look at her and I look at the young dentist that's in my practice now, there isn't any question that the way they're definitely thinking about all these procedures as things they're going to do. Mm-hmm. If you look at the residencies, if they go to a general practice residency or an AEGD, they're placing implants. I mean, they're learning how to do these procedures. So to think that that's going to stop, it's not going to stop. What I ask them, though, is to the trend that I'm most concerned about is the trend towards just learning procedures. Sticking an implant in bone is not that difficult. It's not that challenging. But sticking an implant in bone so that you're going to have it in an optimum position, right, so that the crown and the custom abutment and everything's going to be in the right place at the end is challenging. Mm-hmm. So as we move down this road, we get back to the ethics. What I just implore young dentists to do, no matter how much debt that they've got stacked on top of themselves, is to just begin with that honest, ethical question, whether they have all the pieces in place to get a good result. Mm-hmm. And a lot of times when you do the implant training, you're pretty much being taught to drill this hole and use this spur and put it in like this, but there's not a lot of discussion about the things we're talking about mm-hmm. smile design, about occlusal design, and specifically about where that tooth goes first. So that's where I think, You certainly can do additional training to learn that. Dawson is a great place to go to learn those things. But you can learn a heck of a lot at a study club, and you can learn a lot by hanging out with the right specialist and finding a good mentor.
Yeah.
It's just.
And I want to ask you about that too, because mentors non-negotiable in this industry or this profession. You have to have mentors and you have to choose them. And also study clubs. I mean, I love the idea, and I absolutely insist all the young ones have to get in, mature ones have to be in a study club. What happens in a study club?
One or two.
Or two.
Yeah.
Now you guys, Dawson has its study clubs. What happens inside of a study? If no one's ever been a part of a study club, how does it work?
So what's kind of cool about our study club is that when somebody joins our study club, we typically want our doctors to be interested in our core curriculum or in our core curriculum or have completed our core curriculum. So somebody joins our study club, they immediately get Seminar 1 online. So just like that, they become sort of an alum of ours, and they can go and do their 2.5 days of training online. And the whole goal of the study club, kind of my little brainchild about 5 years ago, was we beta tested it first in Virginia. We had about 20 docs from around the country coming in. And what I wanted to see was if we took our protocol, like you're talking about, our protocol, our study club, or how we work up a case, and we had them come in and we had the models there and we had the photographs and we had the x-rays, and we just allowed them to go through case treatment planning following our checklist, and we could throw, say, 6 cases at them in a year, would they improve? Right. Well, they certainly did, but what it evolved to after that was not everybody only wanted to do treatment planning. And so we're constantly doing interactive lectures. We just did one on wear, and we're doing one on anterior implants and case practice management type topics. But typically what's happening is we have one study club that meets completely online, which is really cool. Mm-hmm. And then we've got a bunch of them that are anywhere from 10 all the way up to 20, 25 docs that get together, and format's different, but it basically accounts for about 6 days a year. Some people might spread that out over a few more evenings or few more half days where they meet once a month for half day, but they can design it however they want to design it. And right. So the study club leaders, what we tell everybody, the way it's designed, because everything is coming from our online portal, they don't have to be educators. We like to say they don't have to be Johnny Carson, just Ed McMahon. They just have to right. kind of be able to lead and welcome everybody and create the structure. But it's tremendously exciting. We, at our alumni meeting, I think you were there for part of study club day. Were you there for part of study?
I was not. That was the first day.
Yeah. So at our alumni meeting, the alumni meeting goes Thursday, Friday, Saturday. Thursday is study club day. So everybody that is in study clubs comes in a day early. They get a day of C included in that. But I'm becoming absolutely convinced, watching our doctors that are committing to our core and in a study club, they learn at light speed because it's constantly being reinforced, and there's a little bit of just peer pressure, if you want to say it, but there's just a little bit of camaraderie and just growth, and maybe even doctors getting together and realizing that some of the challenges that they have aren't unique to them. And so they figure out ways through some of the implementation barricades together. Right. It's really cool. I'm probably most proud of that right now, watching that study club thing take off.
Yeah, it's crazy cool. And I heard this right in that room with you guys. You want to go fast, go alone. You want to go far, go together. And that's really the collaborative experience. Now, I'm going to ask you the tough questions that I get, which is this one. I've always wanted to go to the Dawson Academy, but what if I'm already an established dentist? Do I have to go back to the beginning? And you're doing, you've got some advanced courses, like you're now, there's an all-on-4 course that you guys teach. Can you just give us some perspective?
Sure.
If I'm going to make a decision?
So I think if it's a young doctor that is trying to take his general practice and do cooler stuff. They want to do some veneer cases. They want to do some bigger restorative cases. They want to be able to solve wear problems. then that's the doctor that just needs to sign up for the core curriculum. And the sooner they can go through the 7 classes and implement those protocols. And again, it's not for all their patients, but it's for the patient that has more advanced problems, the worn dentition, the occlusion where they're breaking a cusp off, the patient that wants veneers, the patient that needs some more major crown and bridge. The problem with that patient is we weren't really trained. You can't just prep and pray. You have to figure out where the teeth go and do a wax up and work things out in the temps. And that's what that's all about. For the docs that have been other places and are working at a really high level that want to see what we do but don't want to reinvent the wheel, then I'd say go to our advanced core curriculum or our advanced curriculum. We've got several classes available. The All on 4 class will happen this fall. There's a class on vertical dimension where we talk about opening verticals. Whether you're doing it all at once, we show a cool technique that if you need to open the vertical dimension by placing little tops on the teeth, sort of temporaries, long-term temps, we teach that technique in that class. There is the airway class that I know you've had Whit on, and sort of the medical dental connection. Drew Cobb has an amazing class on TMD and sort of restoring the TMD patient. So I think those types of classes, if you go online, you can look at that, but that will allow you to kind of dive into something that's more complex, but also see how it's founded in what we do.
Right. That's awesome. And so if you haven't gone, like I said, just check it out and go. You have to go. But if you don't want to go, you can also start with a simple thing like online, just to kick the tires, because some people want to kick the tires sometimes. Now, if I want to get a hold of you and ask you a question, how can people get a hold of you?
Yeah, so my email, SmileDoc, SMILDOC. I forgot the E like 30 years ago, and I am the last AOL user in the planet. So it's smildoc@aol.com. Smildoc@aol.com.
Yeah, you are the single last user on the
But everybody has it, so how do you change? I can't figure out how to change. But
do you still hear the "you forgot me"? Do they do that anymore?
No, I don't think they do that.
Oh, it's awesome. Buddy, I am so crazy grateful, and this is just one of many, many, many topics you and I are going to explore. And like I said, I just love your authenticity, your willingness to go where people sometimes don't want to go, and just give us very thoughtful considerations on all sides. And so people can come to their own conclusions. So it's awesome. Awesome. I really appreciate this, brother. So
right.
Hey, wait, hold on. Don't leave yet. I want to talk to you for just a little bit, but we'll say goodbye to everybody else. But hey, for those of you watching, I really, really appreciate it. And again, we're just so grateful you're watching. Please add a question to the feed. Even if you're watching this after the live broadcast, I want to make sure Dr. Cranham gets back to you, and he'll give you a great answer for some of the questions you might have. And then also keep giving us suggestions for great shows. We've got so many of them. I'm going to try to do the best we can to get them all done. And until we see you next time, keep watching the Best Practice Show. You guys have a great evening.
Thank you.